welcome. As people come in, I'll continue letting people in from the waiting room. I'm Barbara Lee Van Horsen. I am the experimenter at the Momentum Center, which is a grassroots movement to create a stigma-free community. And I'm really excited about being able to offer the winter series on mental illness. I see that my slide is incorrect right now. And I also see that, yes, we are recording. So this is on schizophrenia. So I apologize, Michelle, that I didn't get that slide updated. Really thrilled to have Michelle Vandershell here from CMH with us today. There are just a couple of instructions that I want to go through with everybody. First is just a request to stay on mute. But if you're able to turn on your camera, just because having your camera on helps create that sense of trust and community. But on the other hand, I recognize that sometimes it's awkward and uncomfortable to have the camera on. So it's not required, but if you're comfortable enough, please turn it on. Closed captioning is available, so you can request the transcription if you'd like that. And then I'm going to ask that you put your questions in the chat box. And then I'll be screening that chat box to ask Michelle questions after her presentation. And in terms of follow-up, we are recording this meeting. So everybody who's in attendance will get that recording afterward. And any questions that you have, we are going to be happy to answer tonight. So again, really excited to have Michelle Vandershell here from CMH. I'm going to stop sharing my screen so she can share hers, and I will let you take it from here.
Okay. Hello, everybody. I'm very glad to be here. My name is Michelle Vandershell, and I work for Community Mental Health. I have been at Community Mental Health for 24 years, as of November last year. And right now, my job is overseeing all of the adult programming, all of the treatment teams, our clubhouse, our SUD services, what did I forget? ACT, Assertive Community Treatment Services. So I oversee all of the teams that provide those services. It's a lot of dedicated people who have worked in the SMI field for a long time, and I'm really proud of the folks that we have. We've really expanded the number of staff that we have, luckily, through some grants and stuff. So we have about 58 people in the adult department. One of the populations that we serve are persons with schizophrenia. So I am happy to talk about this. I like doing presentations on schizophrenia because it forces me to really keep up on the latest information, the treatments, the statistics, and things like that. So I'm happy to share that with you. I'm going to share my screen. Let's see, hopefully. Okay, does everybody see that? Oh, sorry, I got to click the actual share button. That helps. Okay, you see my PowerPoint up, Barbara?
I see your PowerPoint, and on the side are all the slides.
Oh,
there
okay.
You go. Perfect.
So now you just see the PowerPoint itself?
Yes.
Okay, great. All right. So here's a quick little agenda of what I'm going to be talking about. I'm going to talk about what schizophrenia is and the prevalence of schizophrenia in our society, some of the signs and symptoms, and the diagnostic process that we use to make a diagnosis of schizophrenia. I'm also going to go over some other diagnoses that look like schizophrenia, just in case people have heard of those. And then talk about some of the complications of schizophrenia, such as substance use. And I'm going to talk a little bit about violence and suicide rates, because I think that those are areas of big myths with schizophrenia. So I wanted to touch on that really quickly. And then we'll talk about treatment. And I just like to put this in there because this is what I'm talking about. This is a neuron in our brain. And it's the synaptic part of the neuron where chemicals are transmitted from one to the other part of the neuron. And this is what makes up basically who we are, how we think, everything that we do. So I just like to put that in there. So what is schizophrenia? It is first and foremost a brain disorder. And it's a brain disorder characterized by symptoms that result in people hearing things, seeing things, believing things that aren't true. It can cause problems with thinking. It can cause problems with focusing. It causes problems with cognition, with figuring things out and memory and stuff like that. And it's typically lifelong, but it doesn't have to be life impairing. And if you only take one message away from this presentation, I want it to be that. It does not have to be life impairing. It can be treated. And people can have full and meaningful lives with the right treatment for schizophrenia. So I like to make sure that everybody has that message. So who gets schizophrenia? The rates of schizophrenia vary from about a third to a full percent of the worldwide population. So we figure around 2 to 3 million people in the United States have schizophrenia. About 24 million people worldwide have schizophrenia, been diagnosed with it. It occurs in all ethnicities, cultures, societies, and it's equal among men and women, but it often presents a little bit later in women. We're not quite sure why that is, but men are typically diagnosed earlier. And the typical age of onset, we say, is between 16 and 30. The majority of people diagnosed are usually in late teens, early 20s. That's when we see that peak rate of diagnosis. In terms of a lifetime risk of developing schizophrenia, like I said, in the general population, it's anywhere from 0.3% to 1%. If a child has a parent with schizophrenia, it increases your risk a little bit to 10 to 15%. With two parents, up to 30 to 40%. And this is not, it's 30 to 40% higher than that 1%. So we have to remember, it's still small numbers. What I think is most interesting when we talk about the rates of schizophrenia is the rate of identical twins. So these are people that have identical makeup and neuroanatomy, and they are, it's only in 50% of identical twins that they both have schizophrenia. So that says to us it is hereditary, but there's other things going on. For the great majority of people who get schizophrenia, they do not have a family history of it. And I think that's important to remember, just kind of expresses for a lot of reasons, and we will talk about that. So how is a diagnosis made? And I would like to say very carefully, we use the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. That's the holy grail of what we use to make any kind of diagnosis of mental illness. We use self-report and observations, and we take a careful history if this is done correctly, if it's done carefully. These are the steps that we take. So what we're looking for is a pattern of behavior. So we could see somebody, for instance, our crisis team could see somebody in the ED, and they see some symptoms of psychosis, and they see some symptoms of disorganization and things like that. That's just a snapshot of that person. What we're looking for is a pattern of symptoms and behaviors like that in order to make that full diagnosis. And then we want to rule out other disorders. And I will talk a little bit more about that too. There's a lot of things that could be confused with schizophrenia. And so we want to make sure if we're giving that diagnosis, we're as accurate as possible. So first and foremost, not all psychosis is schizophrenia. Psychosis can happen as a result of a lot of different things besides schizophrenia. And some of those things are drug intoxication. That's one of the more common causes of psychosis. Lewy body dementia or other dementias. That Lewy body is one of the more common ones because it's very, there's a high correlation with hallucinations in Lewy body dementia, but all forms of dementia can include some psychosis at some point. And then, excuse me, delirium caused by medications or electrolyte imbalances. And by that, I mean, I don't know if anybody's ever had a grandma who suddenly gets a little loopy. My grandma would get a little loopy every once in a while. And it was really because of her potassium levels. Her electrolytes were all out of balance. And as soon as those got back in balance, she stopped. One day she actually did see like little green men walking across the living room, and then they went away. So some of those things, those kinds of things can also cause psychosis. Brain injury is another common cause of psychosis. And other mental health diagnoses like depression or bipolar disorder. If those symptoms get bad enough, sometimes psychosis can be the result. And lack of sleep. That's one thing that we always want to rule out. These seem like simple things, but we want to look for these whenever we see a presentation of psychosis to make sure it's not something physical going on. So some of the common symptoms of schizophrenia, we like to lump them into what we call positive or negative symptoms of schizophrenia. And that is, it's one way that we think about them when we're making treatment recommendations. We also think about the difference between these symptoms in terms of medication effects. So positive symptoms are the disturbances in thinking and perception. And it's probably the most common thing that people think about when thinking about the symptoms of schizophrenia. These are the things like hallucinations and delusions or disorganized thinking. The other part of that is negative symptoms, and that is a loss or decrease in normal functioning for the person. So those are symptoms that take away from the typical behavior of a person. Positive symptoms add behaviors and symptoms that are not normal to the experience that we have. So it's just the way of thinking about the difference of the symptoms. And it becomes important when we're talking about medications, because some medications are better for positive symptoms, some medications work better on negative symptoms. And I'll talk in detail about these. So like I said, the positive symptoms, those are the hallucinations, false perceptions of one's senses, like seeing things, hearing things, feeling things that aren't there, smelling things that aren't there. Auditory hallucinations, those are the most common that we see. That's the most common complaint when it comes to hallucinations. Delusions can be present with hallucinations or are separate on their own. These are fixed false beliefs. These are beliefs that aren't based in reality. Somebody's following me, somebody's monitoring me, people are talking to me from the TV, those kinds of things are, well, that's actually hallucination, sorry, but believing things that are absolutely not true. All the red cars are targeted on me and what I'm doing in the community. That might be a delusion that somebody has. And these are outside of cultural norms, because there are some culturally acceptable beliefs like seeing ghosts of people who have died. That would be completely normal in some cultures. In other cultures, we would say that may not be something typical and could be a delusion that ghosts are following me. Disordered thinking is another one of the big symptoms, and that is it's pretty easily recognized. In fact, it's one of the first things that people notice if somebody's become symptomatic. Thoughts jump completely between topics. It's hard for somebody to focus. It may be that they're trying to communicate and their thoughts, they just can't get them out. We call that thought blocking. In the extreme, it can result in what we call word salad. And it's not incredibly common, but it happens sometimes where somebody's talking, but the thought process is just so disorganized at that point that it's just words. It's not words that are connected to each other. It's just words that come out. So we call that word salad. There could also be some grossly disorganized or abnormal motor behavior, including catatonia. And catatonia is the extreme in which people stop becoming responsive, period. and just may almost look waxy in appearance, don't move, just very, very, very unresponsive. So. As I said, the auditory hallucinations most common. 70% of people who experience hallucinations with schizophrenia have the auditory ones. And these can be people commenting, like voices commenting on what they're doing. And that could be like a running commentary, kind of just a voice just basically outlining what the person's doing during the day. Or it could be a voice commenting in a very negative way. Why did you say that? That was dumb. You shouldn't have said that. Those kinds of things. Some people complain about voices just conversing, kind of like hearing people talking all the time, but not necessarily talking to them. It's just this constant chatter. And then sometimes those auditory hallucinations can be of a command nature. We call those command hallucinations, in which the voices are telling them to do something, whatever it might be. Visual hallucinations, seeing things that aren't there, happen about 30% of the time. And that could be anything, seeing people, seeing animals, seeing things that nobody else sees. It can be very scary, very disorienting for people that experience that. And then tactile hallucinations are when they feel things on them, like bugs or people touching them that aren't there, those kinds of things. Not as common. And then the most rare hallucination is olfactory, smelling things that aren't there. And honestly, if somebody complains of smelling something that's not there, they should really get a good neurological workup, because that's a very common symptom of something else, not necessarily schizophrenia or psychosis. Delusions of schizophrenia can be really all-consuming. If somebody has a delusion of being persecuted, it's very hard to control anxiety about that. Some people become delusional about people reading their mind, or people inserting thoughts in their mind, or that everybody can hear what they're thinking. Delusions can also be religiously based. Some people become very grandiose with their delusions. They think that they are the CEO of a company, or they own. I think I had a client tell me once that they had a guitar that was worth, like, I don't know, $500,000 or something like that. And it was a delusion, but I mean, they really believed it. With all of the kinds of delusions that people can experience, paranoia is very common. And that's probably one of the biggest signs of somebody who's suffering with delusions is going to exhibit, is being very paranoid about things. And who wouldn't? If you look at this list, who wouldn't be paranoid if you feel like somebody's following you, or if you feel like somebody's influencing you somehow, or reading your mind? I mean, that would make everybody paranoid. But I think that's one of the things that we notice most easily, is that sense of paranoia. And sometimes that's an early sign that things are maybe going downhill, like maybe we're going to see an episode, and we can intervene at that point if we see that paranoia starting to ramp up a little bit. I talked about the negative symptoms. I mentioned negative symptoms. These are more, these can be more debilitating than some of the positive symptoms in hallucinations and delusions. Negative symptoms are things that, like I said before, take away from who we are as people. So people with negative symptoms can look very flat, very blunted. They're not very animated. Maybe have a blank face, little eye contact. When talking, there's not like this, the hand gestures and the expressive nonverbal stuff that we do. That may be absent. for somebody experiencing negative symptoms. And just lacking energy and spontaneity and initiative to do like a purpose-driven activity. It's very challenging for people that are experiencing negative symptoms. There might be a lot less speech, or the content of the speech may be diminished. We call that poverty of speech. And that's getting like one-word answers to things, not expanding on open-ended questions and things like that. And then anhedonia, which is really tough, and that is where people just don't get a lot of pleasure out of things that they used to enjoy doing, or when you bring up something that was enjoyable in the past, there's kind of this recollection of, no, that wasn't really great, that was really, I didn't have fun doing that. And it's almost like a reframing of those positive experiences. And these can be, like I said, more debilitating than the positive symptoms, a little bit tougher to treat. And I want to make clear that this is not, these aren't personality defects. This is truly part of the disorder. This is part of schizophrenia. So it can be frustrating for caregivers and loved ones of people with schizophrenia when we see these emotions, because I think without that education, we might think, well, they're just being lazy or they're not trying to help themselves. But it is truly a part of this disorder. And so it's something that needs to be treated along with some of those more obvious symptoms like the hallucinations and the delusions. So how do we know if somebody's going to exhibit signs and symptoms of schizophrenia? Well, we often see signs that occur before the positive symptoms, the delusions and hallucinations. And I should mention, when I was talking about the symptoms, in order to get diagnosed with schizophrenia, you must have hallucinations or delusions or disorganized thinking. You have to have at least one of those symptoms. Most people have two, but it has to be one of those three symptoms, and then negative symptoms can also be included in that. But some of the really early signs of schizophrenia that we see are kind of look like those negative symptoms: that social withdrawal from family and peers, maybe odd or unusual beliefs or behaviors, less motivation, less ability to enjoy activities that they used to enjoy. So maybe like that kid who always loved going to play hockey and then doesn't want to go play hockey anymore. Oh, that's dumb, I never liked that kind of thing. Pervasive anxiety, which is really kind of the sign of paranoia. And then maybe disrupted sleeping pattern, sleeping during the day, being up at night. That's a very common pattern for people, not only with schizophrenia, but with serious mental illness, is that reverse sleep pattern. And there's a couple of different theories behind that. I think in part it's because there's less going on at night, there's less stimulation. It's sometimes easier for people that are feeling overwhelmed by everything going on inside to be up at night, and there's less interaction with people. And then changes in appetite and eating can also be a sign. Being unusually sensitive to sensory stimulation, so loud noises seem to bother them more. A lot of activity, a lot of things going on, a lot of light. Those can be, if you see changes in that, that could be a sign. A change or decrease in speech patterns, so maybe speaking less, not engaging in conversation, not initiating conversation. And then that whole social disruption, I don't want to go anywhere, I don't want to do anything. Maybe use of drugs or alcohol, and negative emotional expression. So just everything is seen in a more negative light. Now, any one of these symptoms doesn't point to a sign that we're going to see schizophrenia, but a combination of these symptoms certainly can. And normally we don't notice these things. We don't realize that it was leading to schizophrenia until after we see the emergence of those positive symptoms. So the hallucinations or the delusions or something like that. And then we can look back and say, oh yeah, a couple of years ago, they started doing this and they stopped doing that. And then we kind of get an idea. This is the typical course of schizophrenia. There's that prodromal phase, which is the early signs and symptoms that I just talked about. And then there is an acute phase, which can last from 1 to 6 months. That prodromal phase, I don't know why I can't say that today, but I can. That could last anywhere from a year to a couple of years. The acute phase usually lasts like a month to 6 months, and that's when the psychotic symptoms begin. And then we have a period of recovery, which can last for several months. Positive symptoms can still continue, negative symptoms could be there, and impaired functioning remain. But then things start to get a little bit better, and we move into the residual phase. My point in showing this slide is that it takes a while to recover. It's not like a surgery for like hernia repair or something like that, where you're down for the recovery of the surgery and then boom, you kind of bounce back to the baseline. It takes some time to get back to that baseline or to get to a different type of functioning. It's not something that's really quick. Patience is always necessary, for sure, when dealing with schizophrenia. Because like I said, it's a brain disorder, and anything with the brain takes time to heal. It takes longer to heal than the physical body does. And this, I'm not really fond of this statement at the bottom that some patients will remain chronically symptomatic despite adequate treatment. I just like to emphasize that some, not most. Adequate treatment can definitely bring about relief of positive and negative symptoms. Everybody wants to know what causes schizophrenia, and I'm one of those people. There really isn't any one thing that we can point to. There's not like a specific gene. There's not a specific combination of factors, hereditary or otherwise, that we can say this is what causes schizophrenia. It's likely a complex group of brain illnesses with multiple causes. So it could be hereditary, it could be structural, it could be some sort of influence through environment, toxins, that kind of thing. What we do think is that there's far more people that have the precursors, if you will, for schizophrenia than people who actually develop schizophrenia. So going back to that twin study where I said, if you have a twin with schizophrenia, there's a 50% chance you have it, not a 100% chance, but a 50% chance. What that indicates is both twins had the capacity to develop schizophrenia, but something in the environment kind of triggered those genes to turn on for one twin rather than the other twin. So trauma, consistent stress, those have been indicated to result in higher incidences of schizophrenia. And I should have thrown in there too, drug use, and I will talk a little bit more about that as well. So neuroanatomy, when we look at the brain of people with schizophrenia, we don't see a single change in all people. We can't point to like, oh, it's the hippocampus, oh, it's the frontal lobe. We can't point to one area that we see in all people with schizophrenia. Some may have enlarged ventricles. That is something that we've seen commonly, but not in all. Or an underactive frontal lobe, and this is the area of the brain that's involved with all the planning and judgment, and it's your like executive functioning. Or an overactive temporal lobe, we'll see like increased activity in this area of the brain, which is responsible for perceptions and emotions. And so if you have overactivity in that area, you might be more prone to having hallucinations or delusions. This I just throw in there to show that these are identical twins, and one does have schizophrenia and one does not have schizophrenia. And we do see differences in the middle area of the brain there. And then this is just another example of PET scans. And I don't like that term either, that normal brain versus the brain with schizophrenia. This is a brain that is affected with schizophrenia and a brain that's not affected with schizophrenia. But we see different areas lit up and different areas that are not active. So that darker purpley blue color, those are areas that aren't active in that particular brain at that moment, depending on what they were doing for the scan. So this is how I think of schizophrenia. This is the attention arousal model of schizophrenia. For a long time, I thought that people with schizophrenia just weren't paying attention. It's actually kind of the opposite. It's not that they can't pay attention, it's that they can't tune everything out. So if we hear a loud noise and we get startled, and then we hear it again, it's like, oh yeah, I heard that and I'm not going to jump again. But for somebody with schizophrenia, they have a hard time filtering out all of that extraneous stimuli around them. So they take in too much information from the environment, and it's overwhelming. It's extremely hard to focus. So it leads to withdrawal from social contact because it's just constantly feeling like being bombarded by sensation. That stimulus overload leads to frustration, it leads to poor concentration, it leads to anxiety, difficulty paying attention. So you may ask the same question 3 times of someone, and then they get agitated and answer you. It may be because they were trying to, they couldn't focus on what you were asking, and then it comes out in that frustration and anxiety. So a lot of information may be missed. And that's important to know, because we can't expect to say something to somebody experiencing active symptoms and expect they're going to get it because we said it once. We may need to write it down. We may need to do reminders. We just have to remember that somebody experiencing schizophrenia, their brain isn't going to necessarily process information the same way that we do. And what's really happening is they're trying to process too much information and they get overwhelmed and fatigued. So I just threw in some examples here of some people that are trying to explain what that's like for them. One woman writes, "Everything seems to grip my attention, although I'm not particularly interested in anything. I'm speaking to you just now, but I can hear voices going on next door and in the corridor. I find it difficult to shut these out. It makes it more difficult for me to concentrate on what I'm saying to you." And another one explains what that concentration's like. "It's very poor. I jump from one thing to another. If I'm talking to someone, they only need to cross their legs or scratch their heads. I'm distracted and forget what I was saying. So I think I could concentrate better with my eyes shut." And that's actually very common. We have a lot of people who will sit and close their eyes when we're talking to them, or wear headphones a lot, just to try and block out some of that sound, which is fine. I want to do that sometimes too when I'm in the office. So schizophrenia is a biological disease of the brain, and it's relatively common in the sense that at that 1% level, 1 in 100 people, it's not necessarily rare. It is often misunderstood and stigmatized, and it is treatable. It is not a personal weakness. It's not caused by bad parenting. It's a very, very old theory. And it is not split personality or multiple personality. That still persists to this day, but it is not anything like what we call dissociative identity disorder, which used to be called multiple personality disorder. It's completely different. Some of the, I want to talk a minute about diagnoses that can look like schizophrenia. One of them is schizoaffective disorder. So a lot of times I used to do access work, and so I did intake day in and day out for years, and that was basically doing psychosocial assessments and diagnosing. And I had a lot of people come in and tell me that they were diagnosed with schizophrenia and bipolar disorder. Well, when I hear that somebody was diagnosed with schizophrenia and bipolar disorder, I think schizoaffective disorder. So this is the symptoms of schizophrenia, like the hallucinations and delusions, but also these folks experience major mood disorders. So they can experience major depressive symptoms, they can experience manic symptoms. And so depending on if they experience just depressive symptoms or depressive and manic symptoms, we give them bipolar type or depressive type schizoaffective disorder. Schizoaffective disorder versus bipolar disorder. So how do you know which is what? Is it truly a thought disorder? Because schizophrenia and schizoaffective disorder are considered thought disorders because the thinking is disorganized and it's got those psychotic symptoms, but mostly because of the thinking is disorganized. Bipolar disorder is an affective disorder. So it's like a depressive disorder. It affects your emotions and your affect. So if psychotic symptoms are present in the absence of mood symptoms, then it is schizoaffective disorder. If they experience psychotic symptoms only when they have mood symptoms, then it is bipolar disorder with psychotic symptoms. So the reason I bring it up is because it's confusing. The diagnoses are kind of confusing for folks, but the treatments are tailored depending on what diagnosis you have. Schizophreniform disorder is one of the diagnoses we make if we think it might be schizophrenia, but the symptoms have only been there for 6 months. So that's often a diagnosis that people get the first time they end up in the ED or on an inpatient unit with psychotic symptoms. And then a brief psychotic disorder is made if there's psychotic symptoms lasting more than a day and less than a month. And this is important because we are having a more difficult time, I would say, now diagnosing people that show up in the ED with psychotic symptoms. And the reason for that usually is drug use. A lot of drugs now, well, I shouldn't say a lot of drugs now. We are seeing people using drugs at higher rates that have a tendency to cause psychosis. So like methamphetamine, marijuana with high THC levels in it, and high levels of opiates. Those can all lead to psychosis. And I'll talk a little bit more about drug use right now. So in the CMH world, we assume, and research does back it up, that approximately 60% of all people with severe mental illness also has a substance use issue. And that ranges also on a scale of mild to moderate to severe use disorder. But we assume about 60%. Sometimes it's as high as 66%, depending on the population. And some of the commonly used substances, alcohol is still number one. It's still the biggest issue that we face as a nation in terms of abuse and consequences from that abuse. Marijuana is gaining pretty quickly on alcohol just because it's more widely available, because more states have legalized that, so it's around more. And then some of the other ones, cocaine, heroin, or other opiate use, inhalants, which nasty, but and nicotine. And I'll speak about that a little bit more. For people with thought disorders like schizophrenia, substance can increase, and they can even bring about psychotic episodes. So for anyone that has a propensity for psychotic symptoms, using drugs and alcohol can increase the expression of those symptoms and the frequency and the severity. So smoking, I like to separate out a little bit, only because the prevalence of people with schizophrenia who smoke is very, very high. It's higher than any other mental illness, and it's higher than the general population for sure. The rates range anywhere from 70 to 90% of people with schizophrenia smoke. And there is a reason for that. Smoking has been shown to help with some of those focusing issues that people with this disorder experience, some of those concentration issues it can help with as well as subjectively some of the anxiety issues. But it's a really challenging thing to address the smoking with somebody with schizophrenia, because it can be such a, not a crutch, but a coping mechanism for sure. We have been doing, I should say, more an outreach to folks with smoking issues in our population. We're doing some smoking cessation classes. There's a big push at the state level to make sure that we are assessing everyone that comes in our door to see if they smoke, and offering tools and things to quit. Because it is really hard when you get somebody with a disorder like schizophrenia or bipolar disorder or whatever, and we get them stabilized on their medication and they're doing well, and then they get COPD because they've been smoking for decades. It's really hard. So we really want to focus on that piece of it as well, and make them physically healthy. Marijuana, I wanted to separate out a little bit too in this discussion, because there has been a lot more research being done on marijuana and schizophrenia. And for the longest time, we thought, oh, it didn't have anything to do with whether or not somebody develops schizophrenia. But now research is showing that there is a connection between using marijuana and the expression of schizophrenia. So when I talked about those genes that we have that may lead to a higher risk factor for schizophrenia, research is showing that using marijuana increases that gene vulnerability and increases the risk of developing schizophrenia. So if an adolescent is using marijuana, they're 2 to 4 times more likely to develop schizophrenia. And those that are diagnosed with schizophrenia-induced psychosis, they have a greater risk of, those diagnosed with marijuana-induced psychosis, they have a greater risk of developing schizophrenia over the long term. So it poses the greatest risk of getting or developing schizophrenia over all other drugs. And I share that because it is a huge issue with our population. A lot of folks use marijuana. And again, because it is legal now in our state, so it's around more, it poses a unique challenge in treatment to talk about how it's not great to use if you have a thought disorder. It's a hard sell sometimes, I will say that. So, I mean, just to sum up, drug use increases the psychotic symptoms, it increases the risk of relapse, it increases the number of hospitalizations for sure, and it increases legal involvement. It decreases the medication effectiveness, and our doctor will talk about this ad nauseum with clients about how it does affect our medications. It doesn't mean that we're not going to prescribe those medications, because we will, but it does mean that they may not be as effective. And it interferes with treatment engagement. People miss appointments, they forget appointments, they don't want to come around because they've been using, and they think that the team is going to, judge them in some way. So it really affects that treatment engagement. And then it affects prognosis because continued use leads to poor outcomes for this disorder, as well as other serious mental illnesses, but particularly for schizophrenia. So it is, like I said, a unique challenge in treatment with this population and something that we work really hard on to educate folks about it. I like to think of talking to clients about marijuana use as another form of what we call informed consent. When we put somebody on a medication, we do informed consent. We tell them what the benefits of the medication are, what the risks of the medication are, and what the purpose of the medication is. And I think that it's important to do that with people that use marijuana, to let them know what the risks are, you know, what are you, to find out what they're getting from it. Can we replicate that somehow with something less dangerous, like a different medication? I mean, if you're using it to decrease your anxiety, is there something we can do to address your anxiety that may not be so harmful to your brain? So I feel like we need to do informed consent on this as well. So for the folks that do have both the mental illness and the substance use disorder, we find that in order to effectively treat both, we have to treat both at the same time, equally. And treatment can be varied and it's individualized to whatever the client needs. And that could include residential stays, it can include outpatient services like groups, individual, medication assisted treatment, or a combination of all of it. And recovery does take time. It takes a lot of courage to stick with it. And for most people, recovery happens over months or years. I'm going to talk a little bit about the medications that we use in a second, but when we talk about recovery, one of the most important pieces is to start treatment early and aggressively in the beginning, and that gives us a better prognosis. I wanted to mention a little bit about schizophrenia and violence, because I think this is often a myth, and kind of one of the stigmatizing things about schizophrenia is that people think that a lot of persons with schizophrenia are violent. It isn't necessarily true. I mean, people with schizophrenia are much more likely to hurt themselves and to hurt anybody else, or to be victimized more than the general population. They're just at more risk for that. The biggest predictor of violence is a history of violence. And again, the risk of violence is still very small. So I think this is a good quote, or a good summary of it. Schizophrenia and other psychoses are associated with violence and violent offending, particularly homicide. However, most of the excess risk appears to be mediated by substance abuse comorbidity. And the risk in these patients with the comorbidity is similar to that for substance abuse without psychosis. So public health strategies for violence reduction could consider focusing on primary and secondary prevention of substance abuse. What that is basically saying is that people with substance abuse issues are much more likely to be engaged in violent activities than people with schizophrenia. It's really that substance abuse piece that changes things. And I would say that that is probably true for most serious mental illnesses, whether it's bipolar disorder or personality disorders or anything like that. That substance abuse piece is really bumps up that risk factor greatly. So in terms of public policy, we should focus on prevention of substance misuse and focus on treatment for substance use, because that will greatly decrease risk among populations. And then schizophrenia and suicide. I double checked the statistics on this because the rates of suicide have changed recently over the last couple of years. among the general population. But so far, from what I can tell, people with schizophrenia still hover around approximately a 5% lifetime risk for suicide. And so other disorders and populations have higher risks, including substance use disorder, veterans. There are other populations with higher risks of suicide than schizophrenia. That said, I mean, we certainly take it seriously if anybody's feeling, voicing any of those concerns, and we screen for it all the time, like we do with other mental illnesses. So treatment, what do? It's vital. We want to treat early. We want to treat aggressively because multiple relapses of active symptomology can lead to legal problems. It can lead to hospitalizations, problems with poverty and homelessness, obviously trouble maintaining jobs, and an increased risk of brain injury. And the reason I put that on there is not to indicate that people with schizophrenia get brain injuries, but the act of active psychosis itself is a risk to the brain and brain health. So we want to cut those symptoms down as soon as possible. So what works is medications if they're taken, and that's a challenge in and of itself. Keeping appointments and educating the client, educating the family, educating the caregivers and the loved ones around them about what the disorder is and how we can help, and supporting physical health, as well as support groups, and then psychosocial rehabilitation like Clubhouse, social opportunities like Momentum. And like I said, recovery cannot be rushed in this disorder, so it's important to have patience and understanding and give people time for that brain to heal, and then ask for help when needed. 80% medications are the first line of defense when it comes to treating schizophrenia. So 80% of the people with schizophrenia relapse within a year if they stop their antipsychotic medication. And relapse means active symptoms again. 20% will relapse if they're taking their meds as prescribed. So it is important to take the meds. They work by affecting neurotransmitters. We don't know exactly how, because more research is being done on that. And I will say some of the newer stuff that I read recently is very exciting in terms of new treatments. Longer acting medications in injection form have a better effect, and they are becoming more common for early treatment. In the past, we used to see injectable medication as like the last resort for treatment because people wouldn't take their oral medications. But now we've kind of switched that thinking. And if somebody ends up in the hospital with a first episode of active symptomology of schizophrenia, the doctor is much more likely to consider a long-acting injectable because, like I said, they work better. You don't have to worry about them. You can take them every 2 weeks, every 3 weeks, every 4 weeks. There's even a 3-month shot. And I heard there's a once every 6 month shot now. So it's easier to do than trying to remember orals every day. And if we can knock those symptoms down, that often takes care of some of the resistance to the medications. These are just some of the medications that are out there right now. We call these first and second generation medications. Some of them work for some people and some don't, but we try to find the best one. And if we're having trouble, there is the what we call gene site testing, and we can test people to see how they metabolize the medications, and then we can find the one that best fits them. In addition to the meds, the psychosocial treatments go hand in hand. So like I said, family education, teaching vocational skills, social skills training, the Clubhouse model, which gets people back into the swing of a work ordered day, like doing productive work on a scheduled basis, support groups, case management for helping people connect with benefits and things like that, housing. And this is becoming more and more frankly important to me is helping people become physically healthy. It's also a huge push at the state level, and so we are getting a lot more resources in the community mental health system to integrate physical health care with mental health care because they go hand in hand. So taking care of one's health, getting good sleep, getting good nutrition, limiting, abstaining from substances, having a routine, exercise, everything that's good for everyone else is good for somebody that has schizophrenia. All of these things are brain protective, and that is something that we want to do for somebody that's experiencing a mental illness. What doesn't help? Obviously using substances. High stress environments. It's one of the things we try to limit for people with schizophrenia is very stressful situations or very stressful environments, because often that can trigger active symptoms. It doesn't help to neglect physical health. It doesn't help to avoid treatment, which is not necessarily uncommon because of this fourth one here, not recognizing the need for treatment. And that actually has its own name. It's anosognosia, and that's people who we say lack insight into their disorder. They either don't recognize they have a disorder, they don't believe they have symptoms, they don't believe that they need treatment. And it's extremely common. And it's not something that is willful. It's not something that's even conscious. It's truly part of the schizophrenia. Just like those negative symptoms I was talking about, it's truly part of the disorder of schizophrenia that a lot of people do not recognize that they have schizophrenia. They don't recognize that their symptoms are not real. You know, they're not hearing voices. They don't recognize that the voices are not real. So it is a challenge. What if treatment is refused? I get this question a lot, and my crisis program coordinator gets this very often. People call him and say, my son, my daughter needs treatment. They don't agree to get treatment. What can I do? And so we walk them through this process. We certainly try to engage people in treatment. We try to form a relationship with people because that is, in my opinion, the most important thing that we can do. We sincerely care about the folks that we work with, and we feel like if we can develop that relationship and trust, that people are more likely to adhere to treatment. But there are some folks who will not recognize that they need treatment, and then we end up going the involuntary route. And that is asking a judge to order treatment for somebody so that we can provide the medications and we can provide the case management, we can get them connected to benefits or housing and that sort of thing. We don't like to go that route, but sometimes it's the only option available to us. And so how can we help? We can know and recognize the early warning signs of an episode. So if somebody stops sleeping consistently, if somebody starts isolating more, those may be signs to those around them that they're maybe sliding down into another active episode. So if we intervene, then we can hopefully stop it. Offer help, assistance to connect to treatment providers. It's a hard thing sometimes for people to connect to a treatment provider, to make that phone call or to keep those appointments. We always appreciate people calling and letting us know how their loved one is doing, or if they have concerns, or if they see symptoms. We certainly like those calls. So I would say reach out to providers, even if we don't have a release or they don't have a release to talk to you. You can still share information, and that's still helpful, even if we can't really confirm or deny anything. That happens a lot. And then understand helpful ways to talk to somebody who's actively experiencing psychosis. Avoid confronting or arguing about delusions and hallucinations. You will never win, and it's not worth it. It's real to them, And so we try to speak to the underlying issues instead. Is this causing fear? Are they worried for their safety? Are they super paranoid? Is there a way that we can address that fear? Can we make them feel more safe in some way? We don't have to buy into the delusion, but we can address it in the sense that we can help them feel a little bit more safe. I'll give an example. I had a client that I used to work with, and this was years ago, and very, very paranoid that people were after him, people from his past, and just terrified in his apartment. There was no talking him out of the fact that these people certainly did not care where he was or what he was doing any longer. This was years and years and years between these events. But that wouldn't have gotten me anywhere. It didn't get anyone anywhere. So what we did focus on is how can you feel more safe in your apartment? So we worked on ways that he could get like an alert system if somebody tried to get in the door in the middle of the night. What would happen if he truly just didn't feel like he was safe in his apartment for that day? What other options are there? A friend to stay with or something like that. So we worked that way. I didn't try to, work against that delusion because it was not going to get me anywhere. But in the end, it did help for him to feel more safe by doing some of those other things. And then keep the environment low emotion, low stimulation, and keeping our own anxiety in check is often helpful for somebody who's feeling kind of out of control or overwhelmed. And then there's always a mental health first aid class. They're offered in the community for people, and those are designed specifically for the lay population to gain skills in dealing with mental health crises. And remember, again, recovery takes time. And I think it's important, if we can, to be an ambassador and advocate to those with mental illness and to address the stigma, because it's really, stigma is what keeps people from getting help. And if we can work against that and make it okay to talk about mental health issues and ask for help, more people will get help. So that's
Excellent.
that.
Thank you. Thank you so much, Michelle.
You're welcome. I did put my number and my email there. I am more than willing to talk to people if they have questions about getting help for loved ones, family members, whatever. Like I said, myself and my staff, we do help people walk through that process of where to go and how to get there.
Thank you so much, Michelle. There are some questions, so I'll go right to them. But I also, as a mother of a son with schizophrenia, I just am always so appreciative of the knowledge you share. The first question is, I find a lot of young people that I work with and BIPOC often feel that mental illness is a result of tainted weed and not general use. Dangerous environment for growing brains. How do you address parents that share weed or use weed in front of their children?
That would be probably the biggest issue that the substance abuse professionals are facing when treating the adolescent population, because they're saying, don't do this. For one thing, you're not old enough, you shouldn't do it, it's bad for your brain, yada, yada, yada. And then the kids go home and their parents are smoking weed. So that's very, very hard. I don't think you're going to get very far with the kid in that situation, and probably most of the effort should be with the parent and trying educating them of the effect of their use on their kid. I have heard that argument too, that it's not the actual marijuana, it's just that I got a bad blunt, I got a bad batch, I got a bad whatever, and it was tainted. Almost all marijuana out there that you're buying that's outside a dispensary, and even the stuff that's in the dispensary sometimes, almost all of it is tainted with something. And so any use of street marijuana, and you're taking a big risk in terms of what's in it. So that could very well be. I mean, I have seen some really super bad outcomes of people smoking marijuana laced with acid. I don't recommend that, and it can be very dangerous. But a lot of times they're using it and they don't know. So I guess my simple answer to that is you shouldn't be using anything off the street, or anything, but certainly not anything off the street. So I don't know if that answered the question, but
yeah, I think that's just a struggle. I wish there were an easy answer for that.
That was the concern that I had when we were talking as a state of legalizing the marijuana. It's not necessarily that you know, everybody's going to misuse it, because we have alcohol and, you know, people socially drink and they can use that responsibly too. But alcohol is our biggest problem because it's everywhere. And now that marijuana is everywhere, it is going to be also a big problem and more diversion to the adolescent population. And that was my biggest concern when we were talking about legalization, is that it would be more available to the adolescent.
I think your comment that any weed that you're getting is tainted with something might be helpful.
Yeah.
The next question here, and I have a 3-part question, but the first one is diagnosis. Wondering, do symptoms of schizophrenia appear in childhood, early adolescence, or is the symptom onset closer to teen or early adulthood? When looking for patterns, how far back are diagnosticians looking?
Okay. It is a fairly rare to see a child present with positive symptoms of schizophrenia. What we see generally when we're looking back, when we're seeing somebody with active psychotic symptoms, if we look back, we're seeing those early signs of schizophrenia. So that social isolation, the withdrawal, the lack of initiative, the, you know, just isolating more. I have, in the 24 years that I've been in community mental health, and I did a lot of my work with kids during those years, seen one child that had active psychotic symptoms before the age of 13. Generally, we see more symptoms present at 17, 18, 19, and early 20s.
Thank you. The next question is, can you talk more about the thinking versus mood disorder, as so many of the symptoms seem to be similar to anxiety, ADHD, and depression?
Yep, and they do look the same to some of those disorders because of the disorganized thinking that goes along with a diagnosis of schizophrenia. There's a hard time concentrating, a hard time focusing. But I think the trick with the mood symptoms is that a lot of those negative symptoms I was talking about look very much like depression. So a lot of people that are depressed can't experience pleasure in doing things that they normally enjoy, and they don't have a lot of energy to initiate activities. They don't talk as much, and they isolate more. That all looks like depression too. The way that we determine whether it's schizophrenia versus a mood disorder, though, is they have to have those active symptoms. They have to have the hallucinations, the delusions, or the disorganized thinking.
Thank you. The next question, and there are no more in the box, so please, anybody, if you have any questions, put it in the box. Are there things that we can do proactively to prevent schizophrenia if children are showing signs and symptoms, environmental factors that can turn on the genes?
High stress environment is one of the risk factors associated with development of schizophrenia. So kids that grow up in a really turbulent, traumatic, or stressful environment have been shown to have a higher risk of presenting with schizophrenia. Health, like I talked about the physical health. Again, think of schizophrenia as a brain disorder. So anything that's good for our brain is going to help protect us against brain issues. So good nutrition, good sleep, structure, exercise, all of those things are good preventative factors for kids, and just addressing things as they come up. So I think part of the heartbreak of schizophrenia is some of those early signs and symptoms can kind of go on for a couple of years before we notice, like, oh yeah, you know, well, they slowly stopped seeing their friends, and then they weren't doing any kind of activities that they enjoyed. I think addressing things as they come up, as soon as they come up, is a really good preventative factor as well. Anything that protects the brain would be helpful.
A comment in the box says that flu shots during pregnancy, such as influenza, has been noted as a trigger in the research.
In some research, there has been a tie of viruses to the expression of schizophrenia. So not necessarily the vaccines so much, but getting some type of virus. I'm trying to think of the one with like getting measles when pregnant has been shown to have a higher risk factor, things like that. Whatever protects the mom, though, will generally protect the baby. So I think you're right that there have been some very limited studies that show a correlation, but not necessarily, to my knowledge, any causation. So we can't say for sure that it's a vaccine that does it. The research leans more towards a virus affecting that developing fetus in a more negative way.
Yes, and that comment, the person just wrote, yes, it was meant to say get your flu shot during pregnancy to prevent schizophrenia.
Yes, definitely.
Thank you. Somebody is asking for more clarification about what the term disorganized thoughts means.
Yep. So I'm going to get my DSM out here too, just to explain it just a little bit more. So disorganized thinking results in that speech and that incoherence of having like a clear thought, being able to explain oneself very clearly, being able to explain one's activities. So somebody with really disorganized thinking could be doing the same repetitive behavior over and over, like cleaning or hoarding or something like that, without really being able to explain why they're doing it. It's when we think about disorganized thinking, it can present in a lot of other ways. Like people that are highly anxious can look very disorganized too. And that's one of the tricks in trying to determine whether it's like a schizophrenia, like a thought disorder, or if it's an affective disorder, because we can all look a little bit disorganized. Maybe the easiest way to think about it is to look at somebody with dementia. If you've been around somebody, and a lot of us have known and loved people with dementia, and try and put some reasoning to what they're doing. You often see a lot of repetitive behavior, a lot of forgetfulness, not being able to keep things straight, not being able to follow 3 or 4 step directions. That's very similar to what we would see in somebody with schizophrenia that's experiencing disorganized thinking, just not able to put things together.
Michelle, oh, I'm sorry. Does that answer the question, Pat? I'm seeing, if you want to unmute yourself, Pat.
Yes, it does. Thank you.
Michelle, I have one other question myself.
Sure.
It goes to the idea of smoking. My son is also a smoker, and it's one of those fights that I don't have with him, because I recognize that it does help him. It's a coping mechanism that gives him some relief. But I wonder, is there research going on into how nicotine could be used in a less physically harmful way to help alleviate those symptoms?
You know, I was thinking about that when I was looking through the research again for the statistics, because you're right, the nicotine itself isn't necessarily awful. It's all the other things that are in the cigarettes. And it's really the nicotine that helps with those um, symptoms of like concentration issues and focusing and things like that. The nicotine is actually helping that because it acts somewhat as a stimulant. So no, I'm not aware of any research that is just focusing on whether nicotine can be useful. But I agree with you. If there's some way that it could be isolated, that would be way better than people smoking or even vaping, because that's not necessarily been shown to be so much better. What we try to do is see if there's other ways, like is there a medication that might help with the focusing or attention issues a little bit better than the smoking, and then try and work at it that way. I will say that in all of our SUD trainings now, our annual conferences and our big trainings and stuff, smoking is a really big one to address. And frankly, smoking is harder to quit for most people than heroin. It's easier to get off some other drugs than it is for smoking, just because of the way that it works in the brain, and it creates all of these receptors that are just screaming for nicotine all the time. And they have to die off and prune off when we stop smoking. I did smoke years and years ago. They have to die off when we stop smoking for those cravings to come down, and that's a hard wait. So the thing that seems to work the best is not just one thing. It's like piling them all on. Classes, support groups, medications, mindfulness, acupuncture, throw it all at the person if they're going to try and stop smoking. That's what's been shown to be the most useful, a combination of stuff.
Thank you. Another question, I've heard of the synthetic weed, I think Meridol, as a way to relax and calm the brain. Is there any research on that?
That one I'm not aware of. Is that I'm wondering if it's the same thing that they give people that are going through chemo, because there's a synthetic form of marijuana that they use to help stimulate the appetite and to help with the nausea. I do know that there's a lot of research going on right now with CBD. So THC and CBD are from the same plant, but CBD is technically not supposed to have the psychoactive component in it. And there have been some research studies that show that CBD is helpful for people with schizophrenia.
Okay, and the person has commented that could be, they saw it used for a client with autism spectrum disorder.
Oh, okay. So then, yeah, actually we have found CBD to be helpful for some of the people that we've worked. We don't prescribe it, but this is just anecdotal from parents who are using it with their kids. So I think that might be, I think we're talking about the same thing.
Okay. Are there any other questions? I don't see any questions in the box. I don't see anybody raising their hands or shouting for attention. Oh, I see some words of appreciation.
Oh, thank you.
And let me add mine to that. I'm very, very grateful, Michelle, for your willingness to lead this conversation. And I know that you've already expressed a willingness to come and speak in person. Yes. When we are beyond kind of these COVID cautions. Yep. And feeling that we can gather safely. So I look forward to relaunching this series and inviting you to speak in person. I'm so grateful for everybody who is part of the conversation tonight. And can I get a copy of your slides and share those as well? Yes, absolutely. I'll send those to you. And I would like to thank you for the opportunity to talk about this. This is one of my favorite topics. Like I said, I'm very passionate about working with this population, so I'm just very appreciative that people are willing to listen. Thank you. I am going to put a real quick poll up and ask people just to answer this quick evaluation question. How did you feel tonight's event would impact stigma? no impact, well, make it worse, no impact, decrease it by raising awareness, decreased it and inspired you to take action, decreased and convinced you to become or continue as a leader. And if you would just answer that, and then you have to hit the submit button for that to be recorded. And I can assure you that we will send out this recording of this conversation as well as the slides to everybody here and who registered. We had quite a few people register that I'm sure had conflicts tonight that will be so grateful to receive this. I'll end this poll quickly and just show you we had a really good response tonight. So thank you, everybody.
Thank you.
And until next time, the divine in me recognizes and bows to the divine in you. Namaste.
Namaste.